cultural bleeding clinic, what we do here, and then a bit about the sort of future of what's going on with everything. So a little bit about, sorry, this slideshow is not working for me. That's there. Okay, so cervical smears offered up, just a bit of a refresher, between 24.5 is when the first screen goes, the first recall goes out and stops in your 64th year. So primary HPV testing is now all over England, and in Sheffield, for those that are in this area in South Yorkshire, we started it in about 2013, but it was for the rest of the country was in January 2020. And this resulted in all of the laboratories around this area closing and everything now going gated, as you know. So we test for around 14 strains of HPV, but there are actually over about 100. So the screening programme was formalised in the 1980s, and as we know, it's sort of saved many, many lives over the years, and the numbers are falling every year of cervical cancer. Just some figures there for some numbers from 2022 to 2023, that actually only 67% of women were screened, and only 75% of women between the ages of 50 and 64 were screened. So even though all the work that we do on promoting and everything else, we are still under, quite a long way under for the younger age group, the 80% that we really want to take up the screening. And as we know, cancer, cervical cancer is the 4th most common female cancer in the world. Not so much in the UK, but in the world it's still there. We know it's very treatable, and the whole point of doing smears is that we pick it up very early, we pick up those pre-cancer changes and we never get there. However, if it is diagnosed, it is one of the highest survival rates of cancers in the UK. So if you ever go on gov.uk website, there are lots and lots of flowcharts there telling you about the cervical screening process. So basically, if your virus, the HPV test, is not detected, then you go to routine recall. That slide is thrown out, they don't do anything with it. And that goes on 3 or 5 years, which is dependent on age. If the HPV is positive, that's when they process the slide, look at the cells down the microscope. And as you probably know, if it's negative, they come back to you again in 12 months' time, unless it's a sample taken after a treatment. And then after 3 annual smears showing the same result, they're then referred to colposcopy. If the cytology is abnormal in any way, they get directly referred, or if it's unavailable or inadequate cytology, after the second one, they'll be directly referred. But do remember, over 90% of samples are HPV not detected. And that will be quite apt when we go to HPV self-sampling, which has been a lot in the news this week about that, about the results of the big research study they did. So this is coming hopefully in the next few years, should we say, and that will be a big impact on practice nurses, because obviously the majority of people will not be coming into the surgery for any sort of samples. So the waiting times, anything that we class as high grade, that's moderate, severe, or query invasive, or any borderline endocrine samples must be seen within 2 weeks. Everything else we class as low grade, that's borderline in squamous cells, low grade dyskeriosis, or persistent HPV with negative cytology, or inadequate or unavailable HPV tests are seen within 6 weeks. Over the last year or so, the waiting times have varied a little bit. Since COVID, like everything else in the world, it's all gone a little bit mad, and we are sometimes waiting a little bit longer. Fortunately, in Sheffield, we're not too bad. A lot of the country are waiting 3, 4, 5 months for low grades, but I think we are usually within the 6 weeks. The colposcopy in the Jessup wing, it is trained nurses and doctors who work with the colposcope just to look closely at the cervix. It just magnifies it, and we take biopsies, perform treatments, and make management plans. What we're trying to identify is the pre-cancer cell changes, which we call CIN. We can also pick up CGIN, which is the pre-cancer changes in the glandular cells which line the canal usually. The idea is to pick this up in this stage so it never gets anywhere near cancer. We also have what we call in Sheffield the PCB clinic, and that's very varied. We call it postcortical bleeding clinic. We actually deal with all sorts of things, anything usually related to the cervix that is not related to a smear test. So bleeding after sex, we do sometimes see some of the youngsters with intermenstrual bleeding. We see cervical polyps, anything that looks a little bit abnormal, when you can't get a smear at a doctor's, or anything else that people think are related to the cervix that's not to do with the smear test. So we call it postcortical bleeding clinic, but it's a fairly wide clinic. We've also expanded that clinic recently in the last year because we now do coil fits. So I do a lot of Mirena fits, a lot of Mirena takeouts, and we also, this is where I tend to see the ladies with lost threads. So when you can't see the threads, previously they'd have had a hysteroscopy to get those threads out. So now we see them in one of the PCB clinics. We have various little instruments that we try and get those threads out to save the hysteroscopy appointments because they're waiting for a year to get those done.
Sorry, Rachel.
Yes.
Excuse me. There's a lot of people can't hear quite what you're saying. Would it be possible for you to move closer to your microphone, please?
Yeah. Is that any better with it up here?
I don't know because I'm not having a problem.
Oh, right, okay. Because the volume's rather strange on this. Let me turn it up a little bit as well. Hopefully that's a little bit better.
Thank you.
Can anybody say that's a little bit better? Because I can't actually. Anyway, we'll see how it goes. Right. We'll get to. Okay. So this is just one of the flow charts from for primary HPV screening. So that these are things that are on the gov.uk website that you can look at. This is what we do in colposcopy. So it just gives a bit of a varied overview of things that we do here in colposcopy. So we all work under strict guidance. We try to stick to the government wait times and the results letter timings. We have to see patients within 4 weeks after, once we've seen them in clinic, to perform their treatment. It's monitored from this equipment that we have in the clinic and all those sorts of things. And then we have benchmarks against the whole of the rest of the colposcopists in the UK. We look at the vulva, vagina and cervix, identify the squamous junction and that elusive transformation zone that nobody can ever see. We have various chemicals that we apply to identify lesions, and then we take with punch biopsies for diagnostics, or we perform treatments. So CIN is the pre-malignant, not malignant, abnormal change in the squamous cells, and it represents the amount of abnormal change in the epithelial layers of the cervix. We know progression from CIN to invasive carcinoma usually takes many, many years. However, we know everything can be variable, so we know lots of ladies will go from normal to CIN in a short space of time, CIN to cancer in a shorter space of time. We would generally say it takes 10 to 15 years for that to happen, but we know it can happen much quicker at times. But we also know CIN can just regress itself over time without anything at all going on, without us not doing any treatment. And this is found the regression of CIN, and this is why over 60% of SIN1 will regress on its own without any treatment at all. So that's why if somebody has CIN1 in colposcopy, we will discharge them back to your care to see you again in a year's time for a smear. These are just some of the layers. This is how we define in histology. The amount of abnormal cells in the epithelial layers will determine what grade of CIN we're looking at. So just little pictures that we have from colposcopy. This is showing some wide aceto-white areas of HPV change on a normal cervix. How great would it be if you had a colposcope to do every smear test in the surgery and you could get a picture like that for everybody? It would be fantastic. Again, this is some low-grade CIN changes. You can see the aceto-white changes around the cervical os, mixed with some satellite HPV lesions just around there. And this is what we do. We take a little tiny punch biopsy that is 3 or 4 millimeters. You can see the little area here that's had a punch biopsy taken, that little sample of skin, and we've put some chemical on to stop the bleeding there. Okay. They normally get a little bit of spotting and bleeding for a couple of days, but other than that, there's nothing really from the punch biopsy to worry about. High-grade CIN, you can see it's much denser, is a very, very magnified picture of some high-grade CIN on someone's cervix. It's much whiter, much denser. It's another little picture there, just showing the very magnified high-grade CIN you can identify there. So we would generally perform a treatment for these ladies. We would generally do the loop diathermy treatment and remove that area. Sometimes we do what we call conservative management. So if somebody is a bit younger and their family's not complete and if they have CIN2, then we will sometimes monitor that every 6 months in colposcopy, because we know some loop diathermy treatments, if you have more than one, it can be related to preterm labour or late miscarriages. CIN3 we generally don't conservatively manage, but for some ladies we can for CIN2. So we would treat these with what we call a LETS or a loop cone. It's all the same thing. We do it under local anaesthetic. I'm sure lots of you have been to Colp and seen it. It's quick, simple, fairly effective. We do it for CIN2 and 3. We also perform a loop diathermy these days for CGIN and often lots of early cancers. If that's an early invasion or 1A1, they can be treated completely with just a LETS. As you know, these ladies who have a treatment on the cervix, we discharge them if it's not cancer for a test of cure in 6 months back to the surgery. We often do this on their first visit. So if they have a moderate, severe or query invasive smear, we will do a colposcopy and do this treatment at the first visit if we suspect that they have high-grade disease. It means less anxiety if the lady's having to come back, and no need to come back again. Sometimes they're not built up, they don't expect it, so just get on with it and they can leave and know that they haven't got to come back again. There is also the possibility that we do the treatment and when we send it to the lab, the LETS itself is actually negative. And I've just got some slides for anyone that's never seen a LETS. This is the cervix with the high-grade CIN on the anterior bit here, on the top bit of the cervix. We just have a little loop and hook it up to the diaphragm, and we remove the area from the cervix with a small loop like that. This is the area that we take out. And this is what it's like afterwards. We then diathermy the base to stop that bleeding. And this is when we talk about a post-treatment cervix, when people come in after they've had a treatment, whether that be a few months ago, you can often see this area of scarring on the cervix, which is where it's healed up. Sometimes it won't have this scarring area, but sometimes you will see this sort of almost circular area on the cervix. That's just where the treatment's been. So CGIN is very similar to CIN, but it's within the glandular cells, and those are the glandular cells which are usually in the canal. But obviously, some ladies who have ectropions, where those cells are on the ectocervix on the outside of the cervix, they will be on there as well. CGIN, if left, develops into adenocarcinoma, and these ladies are very difficult to diagnose. It's not always picked up on colposcopy. It's not always picked up on smear tests. And you can have HPV positive And if your cytology shows the squamous cells, it will be classed as a satisfactory sample. So it's quite a difficult one, and they're on the rise. Adenocarcinoma, I think hopefully, I would like to think that because of HPV testing that we actually pick them more and up, and they're always in the cult clinic, but they are renownedly difficult to manage. They often end up with a hysterectomy, even if they've had CG implant, just because we don't know how far into the canal these abnormalities go. So test to cure. So test to cure after treatment, when you see the ladies back in your surgery for 6 months cervical sample, they usually come 6 months after their treatment. If that HPV is not detected after they've had treatment for CIN, they will be recalled in 3 years, whatever their age is. So even if they are over the 50, and they would usually have 5-year recall, they will be recalled in 3 years. If they have had CGIN, after that first 6 months sample, they will be recalled in a further 12 months. And this is why it is so important to put on the history on the request form when you do a cervical sample. And if you're not sure whether to put it on or not, because it was, a year ago, they don't know what samples they've had, then just put it on there. Especially if they've had CGIN, it's really important that it goes on the request form for your cervical sample. If the test of cure is HPV positive, then whatever the smear shows, even if it's negative, they will automatically be referred back to colposcopy via direct referral. Anybody that we see, obviously, that's had cancer and had treatment, they will stay under our care for 5 years, and they will then be discharged to you for further 5 annual samples. Again, that's why it's really important to put their history on there, because the lab won't know that against that. They have 80-something thousand samples that people they deal with, so they don't know who's that. So you must put, if they've had cancer within the last 10 years, you must put that on the request form for the smear test. Other treatments that we do in colposcopy, or not here in Sheffield, but you can also get cold coagulation. I know they do that in other places in South Yorkshire, and that is done for CIN1 and sometimes CIN2. Cryotherapy is used generally for treatments of ectropions that are symptomatic. They always have a punch biopsy before they have this treatment, because it ablates it, it destroys the tissue, there's no sample there, so they must have a biopsy sample before that. I just wanted to pop this slide in to talk to you actually about the new cervical screening management system. I get a lot of queries about this system, because when you look at it, one of the things that it will say, if somebody has been referred to colposcopy, the action will always be suspend, and the repeat will always say 12 months here. So this means this is the sample that they've had taken in July. It was severe. They've suspended it, and they've put the repeat on for 12 months, because that's a fail-safe for that sample. Now, people look at that, and this 12 months won't change. So even when they go to colposcopy, we do a treatment, we discharge them back for a 6-month test of cure. When you look on this program, it will still say repeat in 12 months. It's a fail-safe there. What you need to look at is the bit that says the next test due date, which will give you the correct date there. So this repeat in 12 months will always stay repeat at 12 months. So don't get confused on that, because I get a lot of calls and queries about this. If they've been referred to colposcopy, it will always be suspend in 12 months, and that will never ever change. So you need to be looking at the next test date due, which will give you your next test to do that. So PCB clinic referrals. So anybody can refer into PCB clinic just with a letter through the ERS system. Practice nurses, lots of practice nurses, probably a lot of you have already referred into PCB clinic. When not to refer. I get some referrals where people have come for a cervical sample and they've had contact bleeding. Okay, you don't need to refer somebody just because they bleed when they have the smear taken, and I do get lots and lots of them. If you've seen an ectropion when you do your sample, but they're not having any symptoms and they're not bothered about it, then you don't need to refer that either. If you see an ectropion and that bleeds when she has a cervical sample taken, or she has slight bleeding postcoitally, then that doesn't need to be referred either. Okay, if she's got a normal smear history and if she's got contact bleeding with an ectropion, unless she's worried about it or you think it looks slightly abnormal, they don't need to be referred in. A Nabothian follicle that you look and you think, yep, that's a Nabothian follicle, they don't need to be referred in. And again, this probably sounds like I'm teaching you to suck eggs, but I get referrals every week for, I've seen an ectropion, or she's got a Nabothian follicle. Yeah, I know she's got a Nabothian follicle. They're quite harmless. You don't need to refer them in. However, if you think it looks suspicious, or you're just not sure, or you think it looks a bit dodgy, or you want to check, then refer it in. That's absolutely fine. So the next few pictures, nobody can respond to me, so I'll just gabble on as normal. So the next few pictures have all got a common denominator, and it's not just that they've been referred in to me. Okay, so nice, absolute, beautiful, regular little ectropion. A nice normal cervix that's looking a little bit red in the middle. Little polyp there. Okay. This, yeah, looks a bit strange. This is actually a wart, but it does look a little bit strange. These are some nice Nabothian follicles, a little bit of a cluster of them, just a few together. An atrophic looking cervix. It's quite red, a little bit flat. And a lovely ectropion. Lovely ectropion there. Nice and regular. And again, a few more Nabothian follicles, a few more cysts there on the cervix. So they are all patients that have been referred on a fast track pathway, and somebody thought every one of these was highly suspicious and it looked like cervical cancer. Now, some of them, yes, I can absolutely guarantee these look a little bit suspicious. But, you know, are we actually thinking that pictures like this, these cervixes are highly suspicious of cancer, consistent with cervical cancer? So I'm not saying don't refer anybody in, because obviously if you're extremely worried, then you need referring in. But, you know, these are not 2-week wait referrals. Ectropions sometimes look very strange, absolutely. If you're unsure, refer it in. But just, you know, get a second opinion. Cysts are normal. So just a little bit of a reminder of the risk factors for cervical cancer. HPV is obviously the most biggest risk factor, and persistent infection. We know nearly all cervical cancers are linked with HPV, and the most common ones are 16 and 18. Type 16 is most commonly going to be squamous cell carcinoma, and type 18 will most commonly give you adenocarcinoma. So we know there are lots and lots of ladies who have persistent HPV. Most of the persistent HPV is other, and it doesn't turn to cancer. The 16 and 18, you are most commonly going to turn to cancer if left. Okay. We know one of the biggest risk factors is the early onset of any kind of sexual activity or multiple partners, and that's to do with the amount of partners you have. You are the more likely to be in contact with different types of HPV. Early onset sexual activity, when you go through puberty and you'll have rush of hormones, you will have a big ectropion, and it's the ectropion which is the troublesome area where the HPV can take a hold. That's why it gives you that risk factor. Smoking, we know, lowers your immune system. There's been lots of study with the combined oral contraceptive pill, and it is slightly higher risk if you've been on it for 5 years or more. However, it's not a reason to come off it. It's just a reason to make sure that your smears are up to date. And immunosuppressed women, obviously, they're not fighting off any of that virus there. Bulk samples, just wanted to give you a quick update on bulk samples. They are not part of the screening programme, and they are encouraged not to be done in the surgery still. Okay, so anybody who has a hysterectomy and they have CIN in the hysterectomy, they will have a bulk sample, and they are at risk of developing VAIN, that's the vaginal intraepithelial neoplasia, but these should be done at colposcopy or gynae, not in the primary care. And then the last thing is colposcopy is changing, and I'm sure you've noticed in practice that you are getting more and more ladies 60 plus who are coming back time and time again for the smear test, and this is to do with HPV testing. And I think when we started HPV testing in 2013, certainly in the trial places, nobody expected that actually lots and lots of our older ladies, and I'm including me in that, as an older lady, will be HPV positive. And what we find is we have lots of ladies 55, 60, 65, well into the 70s still having smear tests because they cannot clear the HPV. Lots of these ladies have never had abnormal cells, they have not got any disease. However, they find it really, really difficult to clear the HPV. And this is going to be an ongoing problem. And in the colposcopy life in here, we know that actually ongoing, this is going to be a big problem for colposcopy, because it's really difficult to do a colposcopy on somebody over 65. It's not very adequate. We can't see if the squamous pulmonary junction. We can't say it's an adequate colposcopy. We end up doing quite a lot of treatments on these ladies to prove they don't have any disease. And we've even gone on and done hysterectomies on some of these ladies. Some of these ladies have come back with an early cancer, so the majority don't have any disease at all. However, there's no guidance yet knowing what to do with these ladies. So what I'm saying to you is that you are going to get more and more ladies coming to you for smear tests who are 65 over, because they will keep getting called when they are HPV positive because they don't seem to clear the disease. So it's an unknown management really of this sort of group of ladies, and we don't really know what's going to happen with them. So it is watch this space and see what the guidance will say. Unfortunately, this age group won't improve with self-sampling because everybody's HPV positive. So we're just waiting for some sort of guidance to know where we go with these ladies. So that's about it. Any questions from anybody?
Hi, there's a couple in the chat, so I don't know if you can see them.
Yeah.
Hannah Peck wants to know how we refer to the postcoital bleeding clinic.
So that is like any other referral. It's on the letter that you upload, however you do it into your ERS system.
Okay.
And you just send it to the colposcopy. Send it to the
Yeah.
colposcopy bit, whatever you do it in, and then we'll filter it out from there.
Mm-hmm. My talk is coming last, and I'm one of the gynae cases peer reviewers. If you send it through cases to gynae, we will direct it to the postcoital bleeding clinic and also be able to advise whether or not they meet the criteria that you've already mentioned. Speaking of which, Emma Varley. Sorry, 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 Rachel.
I've started seeing quite a lot of those non-fast track colposcopy forms. I don't quite know where they come from. So they're really starting to come through, and they're quite helpful.
Okay. Emma Varley would like to see the slide of who to refer to the postcoital bleeding clinic again.
Who to refer? Yeah, I'll try and put that in the chat. Try and put some guidance together.
And Katie Whitehead would like to know what would help to clear HPV apart from not smoking. Would it be general healthy living advice, diet, exercise, sleep?
Yeah. And if anybody can devise that, they'll be a millionaire, because nobody can do that one. So it's not smoking and basically, healthy living.
Okay.
Anything that says, I always say to ladies, anything that says will help your immune system may help, but nothing is proven to help to do that. It's always worth a try, but nothing proven yet. You know.
Okay. I don't know if there are any more questions. Oh,
Very nice not having.
that's okay. Alex Hutchinson wants to know, do you ever really clear HPV, or is it just below detectable levels? That's good. They're all good questions.
Absolutely. Yeah, it is. So we say, oh, you'll clear it in 2 years. So it's absolute rubbish. We never clear it. We always have it in our system. It's just that your immune system keeps it below the level we can detect it. And that's why, especially when ladies are getting to the menopause, their immune system's busy dealing with lots of other things, and actually their HPV levels rise. So lots of ladies who have never had different partners, they have the same partner. So they come towards menopause, or they have chronic illness, or they have just a huge amount of stress in their life, and they are suddenly HPV positive. And that's because their immune system just cannot deal with it, and it's become active at that point.
Oh,
So I
that's
always say to ladies,
fascinating.
we measure HPV on a level. So if you sit at this level and the detection level is underneath that level, you will always be HPV positive. So it's kind of on a level that we measure. And if you're just under that level, you're fine. If you're over that level, we'll always detect it.
Oh, interesting.
Yeah.
I don't know if there are any more questions. Here we go. Oh, is there any evidence that vaccinating patients with HPV vaccine who already have HPV is effective? That's a good question.
It is a good question, yes. And the answer is no. So before, we measure everything in before COVID and after COVID, don't we? But before COVID, we were going to start quite a lot of research about vaccinating ladies after they'd had a treatment for CIN to see what was going on there. And I think that will be picked up at some point. However, at the moment, there is no evidence to say it's effective. No. But lots of ladies do to get the vaccine, just to make sure, but there's no evidence to know that that will be of any good. No.
So am I right in thinking that's why they decided to vaccinate children at school, on the grounds that hopefully they wouldn't have been exposed yet? Yeah.
Yeah. And you know, sexual activity doesn't have to be penetrative sex, it can be any kind of contact.
Okay.
Apologies, that was a bit quiet at the start. The sound is come through the speech mic, so it can be a little bit dodgy at times.
Sorry.
Yeah, sorry.
Emma Viley's got another question. Do immunosuppressed women who are HPV positive require different?
So at the moment, the only immunosuppressed ladies are HIV positive ladies who should have annual smears. Anybody else who is suppressed, there is nothing. The smears will be rejected if they're taken early.
Okay. Sally Steele, sorry, unfortunately she didn't quite hear. What about self-testing? I think you did mention it, but
yeah, it did. There has been quite a lot this week because there was a big study. I don't know if any of you were involved in the study last year for self-testing, but they have done a big study about self-sampling, and the results are very positive. So I think it will definitely be coming out in the next few years, because it's very positive effect on uptake and easy to do. So watch this space. But the reports are out today on the gov.uk website about the self-sampling report that they've done recently, and that's ongoing now to know if the self-sampling is positive for HPV, because that's all they will be testing. They'll be testing HPV, so it's just like a swab, it's just a DNA test. You don't have to hit the cervix. The HPV will be in the cervix and the vagina, so you just have to waft a swab up there to pick up the HPV. So if that's positive, then they don't know yet where they'll go from that, but the response for doing that self-sampling test, people found it very easy and it seemed to be quite effective. So I think it's definitely something that's going to be coming in the next year or two, I would think.
Excellent, thank you.
Welcome.
Any other questions?